So, um, when you usually picture cosmetic medicine, you're probably thinking of something, highly visible.
Right, like someone walks out of a clinic and it's right there on the surface.
Exactly. A smoother forehead, maybe a sharper jawline, fuller lips. But as we dug into the data for you today, looking at everything from UK government regulatory documents to these like private clinical guides from Beverly Hills aesthetic surgeons, a totally different picture emerged.
Yeah, it really did. There is this massive, booming, multi-million-dollar sector of aesthetics that is entirely hidden from the public eye.
Right. We are talking about procedures happening where the sun quite literally does not shine.
Yeah. It is a completely distinct frontier of medicine, and it's growing exponentially, but largely in the shadows.
Because it sits at this really complicated intersection, right? Like clinical anatomy, aesthetic desire, and deep personal privacy.
Exactly, which makes it hard for people to get good information.
Which is exactly our mission for this deep dive. We're taking this huge stack of sources, and we want to cut through the societal taboo and, honestly, all that heavy medical marketing jargon to help you understand the actual biology behind two specific, incredibly popular injectables.
Yeah, we are putting the external procedure, which is often called labia, puffing head-to-head with the internal G-shot.
Because even though they might use similar materials in the syringe, the clinical goals, the anatomical targets, the effects on the human body, they literally could not be more different.
The underlying motivations are night and day. I mean, on one hand, you have a procedure designed to restore structural integrity, right? Like mechanical protection.
Yeah.
And on the other hand, you have this highly targeted intervention designed solely to amplify neurological sensation. Pleasure, basically.
Okay, so let's unpack this. To really grasp the mechanics here, we have to start on the outside and look at the biological wear and tear that these tissues endure.
Right. The daily mechanical stress.
Exactly. So think about the high-end gel upholstery on a professional road bike.
Oh, that's a good analogy.
Right. Its entire job is to absorb kinetic energy and just provide a protective cushion against friction. And when you look at the architecture of the outer vulva, the labia majora, its primary evolutionary function is to act as that protective shield.
Yeah, protecting the highly sensitive, really delicate structures underneath.
Exactly. It's essentially a fatty pad supported by this dense web of connective fascia.
And just like that bike seat upholstery, the biological padding degrades over time.
It loses its stuffing.
Right. And the sources detail this really fascinating cellular cascade that causes the deflation. The most universal trigger is actually the hormonal shift associated with menopause.
Okay, so what exactly is happening at the cellular level there?
Well, as estrogen levels drop in the body, the estrogen receptors within that specific vulvovaginal tissue, they basically stop stimulating the fibroblasts.
And fibroblasts are the cells that make collagen, right?
Exactly, collagen and elastin. So as that production stalls, the tissue literally loses its structural scaffolding.
Wow. But I want to point out, the clinical literature makes it really clear that this isn't just an aging or menopause phenomenon.
Yeah, not at all.
Like massive weight loss can rapidly deplete the localized fat stores in that area.
Yeah, that's a huge factor.
And then, of course, there's the sheer mechanical trauma of childbirth. I mean, that can stretch and tear the underlying fascial network so severely that the tissue it never quite retracts back to its original position.
Right, and the result of all of this, whether it's hormones or weight loss or childbirth, is deflated, sagging, or, deeply wrinkled outer tissue.
Which brings us to the functional consequences, because those are severe.
Oh, absolutely. When you lose that natural biological shock absorber, daily life gets incredibly complicated.
Yeah, the sources highlight patients experiencing chronic chafing and microabrasions just from wearing tight clothing.
Yeah, we're trying to exercise. I mean, high-impact activities like running, cycling, horseback riding, they generate direct shear stress on the inner tissues because that outer protective barrier is just, well, it's compromised.
Right. Even sexual intercourse can become outright painful for these patients.
Exactly. So the mechanical problem is a lack of volume.
And the clinical solution presented in the texts is labial puffing.
Right.
Which, wait, I need to bring up a major point of confusion here to clear this up for you. Because when people hear about cosmetic procedures in this area, the word that usually dominates the conversation is labiaplasty.
Oh, yeah. People mix those up constantly.
Right. But a labiaplasty is a surgical procedure of subtraction. Like a surgeon physically cuts away and removes tissue, usually from the inner labia minora, to stop it from protruding.
Yeah, it's a trimming procedure.
Exactly.
Yeah.
But labial puffing is the exact opposite. It is non-surgical, And it's a procedure of addition. You're injecting volume back into the outer tissues.
And that surgical distinction is critical. With puffing, doctors are utilizing dermal fillers.
Right, like Deserial.
Yeah, most commonly a high-density hyaluronic acid, or HA filler, like Deserial. They basically map out the depleted areas of the labia majora and inject the filler directly into the subcutaneous layer.
Okay, let's get into the chemistry of HA for a second, because it's not just um, like a physical spacer pushing the skin up, right?
No, not at all. It's much more active than that.
Because hyaluronic acid is naturally occurring in the body anyway, and at a molecular level, it acts like this intense biological sponge.
Yeah, it's a type of molecule called a glycosaminoglycan, which is a mouthful,
I don't even
but
prove it.
basically it has a highly negative electrical charge, which means it acts like a molecular magnet for positively charged sodium ions.
Okay, and where sodium goes, water follows.
Exactly. So when the HA is injected, it doesn't just sit there like a lump, it actively draws systemic hydration into the labia.
Oh, wow.
Yeah, it dramatically plumps the tissue from the inside out and restores that supple, shock-absorbing quality.
And because it's non-surgical, the clinic protocols note this takes, what, like 15 to 30 minutes?
Yeah, about that, under a local anesthetic.
Right, and patients are basically walking out the door and resuming normal life the exact same day.
It's remarkably fast.
So that solves the mechanical friction problem on the outside. But as we saw in the research, people aren't just looking to avoid pain.
No, they're actively seeking pleasure.
Right, and that entirely different motivation requires us to shift gears and look at the internal anatomy. We're moving from the outer labia to the anterior vaginal wall and, well, the elusive G-spot.
Yeah, the clinical shift here represents a completely different set of physiological goals.
Okay, but I have to stop you right there and I need to push back on this premise.
Oh, okay.
Because the G-spot is heavily debated in the scientific community.
It is, yeah.
Like for decades, peer-reviewed journals have literally argued over whether it's even a distinct anatomical structure or essentially just this anatomical ghost that only exists for, like, a fraction of the population.
That's a very fair point.
So how do these clinicians justify taking a syringe to an area that might not even exist for the patient sitting on the table?
Well, it's interesting because the medical literature you're referencing actually validates your skepticism. And the clinical guides for the G-shot, they acknowledge it directly.
Oh, really? They don't try to hide it?
No, because they clarify that the G-spot is not a distinct standalone organ. It's not like a kidney or a spleen.
Right.
Modern pelvic anatomy defines it more as a highly sensitive erogenous zone. It's this dense convergence of nerve endings intimately connected to the internal crura, or the legs of the clitoris.
The external clitoral network.
Exactly. And it's located about an inch or two deep on the front wall of the vagina.
Okay, so the nerves are definitely there, but they might just be buried or anatomically tricky to access for a lot of people.
Precisely. Because under normal physiological conditions, during arousal, increased blood flow causes vasocongestion.
Like swelling.
Right, that anterior wall swells and thickens, making those nerves more accessible. But human anatomy is incredibly variable.
Yeah, no two bodies are the same.
Right, so for many women, that natural vasocongestion simply doesn't create enough of a protrusion to allow for consistent stimulation during penetrative sex.
The nerve cluster just kind of remains flush against the wall.
Exactly.
Okay, wow. That structural reality completely reframes the purpose of the G-shot for me. Because the injection isn't trying to, like, create a new organ. It's just trying to force a physical protrusion.
Yes, you're creating a structural change to access the nerves.
Right. By injecting a dense HA filler or sometimes medical-grade collagen directly under the mucosal lining of that specific zone, the tissue is physically expanded. It basically creates a localized biological speed bump.
A speed bump is a perfect way to describe it. You are drastically increasing the surface area. By forcing that localized bulge to project lower into the vaginal canal, the filler ensures that the nerve cluster sustains direct, continuous friction during intercourse.
That's fascinating. But the logistics of actually locating the target in the clinic, that blew my mind.
The mapping process?
Yeah. Because the anatomy is so individualized, a doctor can't just, measure 2 inches in and press the plunger.
No, definitely not.
The patient has to guide the map. The guides we looked at detail that the patient is positioned similarly to a routine exam, like a pap smear, but they are actively involved in self-examination to pinpoint their exact point of maximum sensitivity for the doctor.
It has to be a collaborative process to be effective. The doctor can't feel what the patient feels.
Right.
So once the patient identifies that neurodense epicenter, the clinician applies a topical numbing agent, utilizes a specialized speculum to isolate the anterior wall, and then delivers the filler.
I mean, if you're going to undergo an injection inside the vaginal canal, the data better support the outcome.
Right, and it seems to.
Yeah, in the pilot studies referenced in our stack, 87% of the women who underwent the G-shot reported a significant enhancement in sexual gratification and arousal.
That's a massive success rate.
It really is. They physically bridged the gap between the anatomy they had and the stimulation they wanted. But, whether we are talking about the internal G-shot or the external labial puff, we really have to talk about the lifespan of these building materials.
Yeah, longevity is the big catch with HA fillers.
Right. Because the body recognizes hyaluronic acid as a native biological substance, your metabolism eventually just breaks it down.
Exactly. The enzymes in your body, specifically hyaluronidase, will naturally cleave those HA chains. So whether it's acting as a cushion on the outside or an amplifier on the inside, the filler will degrade.
And the consensus across the clinics is a lifespan of roughly, 6 to 12 months before a patient needs to return for a top-up.
Yeah, usually around the 9-month mark, people notice it fading.
But our sources detail a much more permanent alternative for the external procedure, which I found so interesting. For patients who want to restore the labia majora without, an annual subscription to HA fillers, surgeons are using what they literally refer to in the text as liquid gold.
Yes, autologous fat transfer.
Yeah. Which means taking living tissue from one area of the patient's body and grafting it to another.
Right. It's your own fat.
Yeah, and the process is basically a dual procedure. A surgeon performs a gentle liposuction, typically on the inner thighs or the abdomen, to harvest the raw fat. But, and this is key, they can't just inject that raw material directly into the labia.
No, it has to be purified first.
Exactly. They put it through a centrifuge system. They spin it down to separate the oil, the blood, and the tumescent fluid they use during liposuction. And that leaves behind only the most viable, purified fat cells.
And the reason cosmetic surgeons revere this purified fat as liquid gold is because of its cellular composition. It is incredibly dense with adipose-derived stem cells and natural tissue growth factors.
Oh, wow.
Yeah, so when this purified fat is injected into the deflated labia majora, those stem cells actively promote tissue regeneration. They actually improve the skin quality in the area over time.
That's incredible. But the survival of that transplanted fat is a brutal biological numbers game, isn't it?
It is. It's not a guaranteed survival rate.
Right, because unlike an inert HA gel that just sits there holding water, living fat cells require a blood supply to survive.
Exactly. They require immediate vascularization. Once they're injected, those fat cells undergo a literal race against time called angiogenesis.
Which is the sprouting of new blood vessels.
Right, the physiological process of sprouting new blood vessels from existing ones. If a transplanted fat cell doesn't tap into that localized capillary network within roughly 48 hours, it gets starved of oxygen.
And then it just dies.
Yeah, it undergoes apoptosis, which is programmed cell death.
So the clinical reality is that about 20 to 30% of the transferred fat simply doesn't survive the move.
Yeah, the body's immune system just clears away those dead cells.
Okay, so how do surgeons deal with that? Do they just accept the loss?
Well, they anticipate that attrition rate by deliberately over-injecting the labia majora during the initial procedure.
Oh, they overcorrect.
Exactly. So the patient actually leaves the clinic looking perhaps more swollen or puffed than desired. But over the next 3 to 4 months, as that initial percentage is reabsorbed, the remaining 70 to 80% of the fat permanently integrates.
And it establishes a robust blood supply.
Yes. And from then on, it behaves just like native tissue, completely eliminating the need for annual top-ups.
Okay, it's an elegant, permanent biological solution.
Yeah.
But, hearing how refined these techniques are, like how quick a hyaluronic acid injection is or how seamlessly fat can be transferred, I feel like it creates a very dangerous psychological trap for the consumer.
100%. It breeds complacency.
Right. There has been this massive cultural shift in how we view medical procedures. Because these injectables are marketed as, non-surgical lunchtime treatments, people subconsciously categorize them alongside getting a facial, a chemical peel, or like a blowout.
And that psychological shift treating invasive tissue manipulation as casual self-care is the exact catalyst for the regulatory crisis we are seeing in the UK government documents from our stack.
Yeah, the commercialization of aesthetics completely outpaced the legal frameworks meant to ensure patient safety.
It became a free-for-all?
The documents describe a literal Wild West.
Mm.
We're looking at reports of totally unregulated practitioners administering genital fillers in hotel rooms, rented Airbnbs, converted garden sheds,
It's terrifying. There is no sterile field, no emergency protocols, literally just a syringe and an Instagram booking page.
which is insane.
Yeah.
So if we look at the UK government's intervention, they're utilizing this strict traffic light classification system to try and regain control of the industry.
Right. They're aggressively stratifying the risk of different procedures.
Okay, so a green procedure might be like standard microneedling.
Yeah, and an amber procedure includes things like Botox or basic facial fillers, which obviously still require oversight but have a really well-documented safety profile.
But injecting filler into the breasts, the buttocks, or the genitals, which explicitly includes both the labia majora and the internal anterior vaginal wall, is legally categorized as a red procedure.
The absolute highest tier of medical risk.
Right. And I think people might wonder, why is the pelvic region so much more dangerous to inject than someone's forehead or their lips?
It all comes down to the unforgiving nature of pelvic vascular anatomy. The genital region is not just some simple inert pad of fat. It is a highly complex, interconnected grid of major blood vessels,
Right.
specifically the internal pudendal artery and its numerous branches, and they are running right alongside dense nerve bundles.
Okay, so imagine a major city's traffic grid, right? You have massive arterial highways bringing oxygen-rich blood into the neighborhoods, and then a network of smaller veins taking the deoxygenated blood away.
That's exactly how it works.
So when an unqualified practitioner in a hotel room blindly pushes a thick, viscous HA gel, or, harvested fat into that area, they run the risk of an intravascular injection.
Which is the worst case scenario.
Yeah, they accidentally puncture the artery and inject the filler directly into the bloodstream.
They essentially create a biological concrete roadblock on that main highway. It is called an arterial occlusion, and the filler instantly halts the flow of blood to the surrounding tissues.
And the physiological cascade that follows an arterial occlusion is just a nightmare scenario.
It happens so fast.
Yeah. Without fresh oxygen, the tissue enters a state of ischemia. Within hours, the cells begin to swell and rupture. It triggers this massive inflammatory response, and the tissue literally begins to die.
Necrosis.
Right.
And necrosis in the genital region is catastrophic. It can lead to permanent disfigurement, the loss of functional tissue, and profound, chronic pain.
Oh, man.
And honestly, even if they avoid an artery, just performing these deep tissue injections outside of a sterile clinical environment introduces an enormous risk of systemic bacterial infection.
Which makes total sense, and it's exactly why the new regulations demand that red category procedures be legally restricted to highly qualified, regulated healthcare professionals.
Right. Surgeons or specialized gynecologists who possess a really granular understanding of pelvic anatomy.
Exactly. And they mandate that these procedures only occur in care quality, commission-registered clinical premises. Like, they have to have hyaluronidase on hand to immediately dissolve the filler if an occlusion occurs.
They need the infrastructure to manage severe complications. The safety net cannot be an afterthought. It must be an absolute prerequisite.
Because you are manipulating an incredibly complex biological system.
Exactly.
Well, it is a lot of complex biology to synthesize, so let's zoom out and look at what we've unpacked for you today. On the external front, we have labial puffing. Whether utilizing the hygroscopic tower of hyaluronic acid or the stem cell-rich permanence of autologous fat transfer, the goal there is structural restoration.
Right, rebuilding the biological shock absorbers.
Absolutely. Rebuilding the labia majora to eliminate mechanical friction, ease physical discomfort, and reverse the atrophy caused by estrogen loss or childbirth.
And then, contrasting sharply with that, we explored the internal G-shot, a procedure that leverages similar injectable materials but for a wholly different human motivation. It is a targeted, patient-guided intervention designed to force a physical protrusion on the anterior vaginal wall, increasing the surface area of that highly sensitive nerve cluster to amplify physical friction and maximize sexual gratification.
Two procedures, literally separated by a matter of inches, but addressing completely different aspects of the human experience. Mechanical protection versus neurological pleasure.
It really highlights how far the field has come.
Yeah, I mean, science and aesthetics have evolved to a point where we have this unprecedented, customizable control over our own biology. But as the UK regulatory crackdown proves, Treating these profound anatomical interventions as casual spa days invites catastrophic risk.
Absolutely. The sophistication of the tools requires an equal level of sophistication and respect from both the practitioner and the patient.
So true. Well, as we close out this deep dive, we want to leave you with a broader thought to chew on. We started today by discussing how cosmetic medicine used to be confined to the visible surface, right? Smoothing out the face for the world to see. But now we're utilizing advanced injectables and fat grafting to alter our most hidden, intimate biology.
And that clinical blurring of cosmetic aesthetics and functional sexual wellness forces a real societal reckoning. I mean, as these intimate enhancements become more accessible and mainstream, how will this ability to customize the invisible change our collective definition of what a normal human body should look like?
Yeah.
And perhaps more importantly, as we engineer tissue to maximize sensation, how will it change our expectations of what a normal body should actually feel like?
Wow. The definitions are definitely shifting fast, and the implications go way beyond the syringe. Thank you for taking this deep dive with us, exploring the complex medical realities hidden just beneath the surface. Keep questioning the consensus, keep looking at the data, and we will catch you on the next deep dive.